Perfect. I love being the last talk of the day because no one's paying attention. So a couple things quick. Just some of my disclosures. I also want to disclose that I'm going to bash a procedure that's one of the most commonly performed procedures in the United States, so please don't hate me. So I think when we talk about MIS, we really need to get on the same page, because what are we really talking about, especially in degenerative procedures? Right? Are we talking about expandable retractors? Are we talking about tubes? Are we just talking about placing percutaneous pedicle screws? Or are we really talking about doing Wiltse approaches and going in and dropping it? Or even more, are there other procedures that we consider MIS at this point in time? Jim loves his endoscopic surgery, even though I have no idea where the nerve root was there. But are we talking about mini open A-lifts? Are we talking about lateral fusions? Are we talking about anterior to the psoas? These are all considered minimally invasive procedures. But what I really want to talk about today is probably the MIS TLIF, which is probably, again, one of the most commonly performed procedures. So if we just Google minimally invasive spine surgery, like most of my patients do, and become more informed than me, we find nothing more than advertisements at the front of the page. And interestingly, I'm in Denver, and I found it very interesting that on the first page, in fact, before another big group in Denver, that the Georgetown guys showed up on my Google search. Found that pretty impressive. Good job, Fred. But seriously, it's really, before when you put this in, really we find nothing but advertisements. That's really what we find out when we do that. So instead I said, well, what's really minimally invasive? So I thought, well, what if we didn't put anything in? I Googled uninstrumented spinal fusions. And what do we find with that? Well, I found great papers that had a lot of good literature, that were award-winning, with really long-term follow-up, like all the MIS procedures. But then I realized I was really thinking about the wrong thing, that I needed to think about putting pedicle screws through tubes, putting bone graft through tubes, and getting fusions. So I thought, well, why not an instrumented non-fusion, because that's what we're really doing. And so when I looked at that, I tried to Google it again. I found this. All I came up with was this lumbar arthroplasty stuff with Dr. Yu. So again, I had to go back to the drawing board, and I thought, okay, MIS TLIF, what can I do? And really, this is the assumptions that we have. Lower blood loss, lower infection rate, they get out of the hospital a little bit quicker. Maybe you can get back to work a little quicker, less morbidity and mortality, and lower cost, of course, which we're going to go into a little bit later. So when we did that PubMed search, what do we find is that a bunch of articles, none of which have really long-term follow-up. But in the last year, everyone's convinced themselves that MIS surgery is the way to go. And so now we're arguing in the literature about what the best way to perform an MIS procedure is. So what does the literature really show us? This is a pretty good review of what all the studies have showed us. And there are some advantages to an MIS TLIF, which we'll go over in a second. But higher revision and readmission rates, exposes the surgeon as well as the patient to extensive radiation. We really don't know how it affects the patients. And what's most important in all of medicine is that the advertising climate is really favoring MIS right now, and that's important. So what are the advantages? Well, we get, at 2 years, perhaps a reduced societal cost, less medical costs, reduced time to work, as well as improved ODI in the short term. Really nothing's shown much of a difference after those 2 years. What do we get if we're just busy surgeons and we do it open? Well, if we look at that, we find we get lower morbidity and mortality, shorter length of stay, less readmissions, and lower costs. So is it really that it's MIS, or is it just a more experienced surgeon? That's what I would just have to ask. So what are the problems that we do think about, and what are some of our solutions for these that might be creating the problems that we know? Well, we know there's a learning curve. I think we discussed this with endoscopic surgery, as well as an MIS TLIF. We know this is going to happen. So that's going to be something that's there. Radiation exposure. Okay, we know this is there. We've also created some solutions to help with this, at least for the surgeons and the staff in the OR. So let's go to that learning curve. It's a steep learning curve. Somewhere between 10 and 44 cases to learn an MIS TLIF. If that's the only procedure you're performing, that might not be that bad of a learning curve. But if, like most of us surgeons, I think we're performing a lot of things. So what have we decided to do? Well, let's just make sure that we get residents and fellows doing MIS. Some of them, maybe all MIS, in fact, as we teach them. So next, we had to figure out what to do about radiation. Fortunately, industry, not Innovasis, came to the table, and I'm not ripping on Innovasis, I'm ripping on industry. With navigation, now we can do intraoperative CT. Surgeons can stand out of the room, not get any of that radiation, but we can blast the patient with a ton of radiation, which we aren't studying. So we put that all together, and we've even gone a step beyond that. We've created augmented reality for the OR. We can also blast them with radiation, give us really cool headsets to look at, which are almost as cool as having a heads-up display in your ski goggles. So what does that all really mean? Now we're training our residents not to know their anatomy, not to open anything, to rely on a CT scan. And I don't know about you guys, but in my neck of the woods, average MIS TLIF at my hospital that I'm not performing has an average somewhere between 6 and 13 hours for a 1 level. So I would say, you know, what are we really teaching these people? So industry again comes up with another solution. If you don't know your anatomy, we can have a robotic arm that can tell us where to put a pedicle screw and where to throw a graft, and they're going to continue to push this. None of which is actually reducing costs, which was one of the benefits of an MIS surgery. But I also, just to leave you on a happy note, I know it's here to stay. There's nothing I'm going to do about it. I can't stick my head in the sand. So for all of you guys who are not MIS surgeons, there's probably not many of them, this is my pep talk for you. You're going to have to get used to it, but robots and navigation are very cool. Nothing hurts results more than follow-up. And you don't have to round as much because the patients leave the hospital. And you guys can read the rest. Thank you very much.